Okay, so your midterm exam is not next Monday, but it is the following Monday. And it's going to be in class. So you'll just come to class and you'll have that time to take the exam. You'll notice here that I have given you kind of a list of all the major topics that we've talked about. So you could go through here and just make sure that you understand what that reference is to. And then I have the essay questions. So the essay questions on the midterm and the final exam are verbatim. So they're taken exactly from this sheet. So you know exactly what the essay questions are going to be, but I'm not going to ask all of them. So I kind of randomly pick 2 or 3 to put on the, it'll be 3, midterm exam, and then I put 2 to 3, the midterm exam. Okay. So one of the nice things about this is that when you answer these essay questions, they will also help you answer the multiple choice questions. And so oftentimes, you know, if I give the essay question number 1, then I might not have a lot of multiple choice questions about action potentials, right? But if I don't give a question about the stuff on number 2, then it will be incorporated into a multiple choice question. And so I think that it is a good way to learn. So you won't have notes for this. You can work together to study for it, but you won't have notes coming into the class. So it's closed note, closed book. Okay. Are there any questions? Yes.
Are we going to be doing like a review?
We might have a half a day for a review day. Yep. So also remember that we have one more lab before the lab practical. And so the lab practical is where you're going to need to be able to identify the structures on the models, the slides, and then possible diagrams that I've given you in lab as well. So the brain model, for example, and the cranial nerves. And the dissection of the sheep brain.
That's on Friday before.
That is the Friday before. And so I actually think it kind of works out nice because you learn stuff and you study for the lab practical, and that actually additionally helps you get ready for the midterm exam, which is on Monday. And so I'm going to have you turn in your lab notebooks when you come to the midterm exam. So you'll have your lab notebooks to study. Okay. Okay, so we're talking about the peripheral nervous system. So remember that nerves are not found in the brain or the spinal cord. And the other thing about nerves is that they are actually organs. So they are not just nervous tissue. So they're considered organs. And the reason for this is that there's not just nervous tissue, there's actually connective tissue, and there's actually blood vessels that serve the nerve and provide nutrients. And so remember when we talk about nerves, these are bundles of myelinated axons. So in the case of the peripheral nervous system, what type of glial cell is responsible for the myelination? What is the name of the glial cell that provides the insulation around the axon? Anybody know? They are referred to as Schwann cells. I think these are the only glial cells that are actually named after a person. So Schwann was a person. That is not a descriptive, like oligodendrocyte means few branches, right, of the cell. So Schwann cells are what create the myelination. Okay, so those are bundles of myelinated axons. So when we talk about nerves, we can say that some of these axons are also referred to as fibers. Which is kind of confusing because we have nerve fibers, but we also have muscle fibers. And muscle fibers are muscle cells, but they're also called fibers. So axons are called nerve fibers. So we can have sensory fibers in a nerve. So we can have sensory fibers. We can have motor fibers. And I wanted to point out that the motor fibers could be skeletal, so they could be going to skeletal muscle, but they could also be going to smooth muscle and glands and the heart. And so motor just means that it's sending a signal out to cause an effect. So we're going to talk about the autonomic nervous system versus the somatic nervous system. The somatic nervous system deals with motor neurons that go to skeletal muscles, whereas the autonomic nervous system deals with smooth muscle, cardiac muscle, and glands. Okay, so those motor fibers could be going to skeletal muscle, right? Smooth muscle, cardiac muscle, and glands. Some of our nerves are said to be sensory only. So for example, the olfactory nerves are sensory only. The optic nerves are sensory only. But if they contain both, which is common and is only found when we look at the spinal nerves, all the spinal nerves are actually mixed nerves. So what it means to be mixed is that they have both sensory and motor function. So if we look at the structure of the nerve, it has different levels of organization. And so you'll notice here that we looked at this actually in lab when we looked at a cross-section of a nerve, and you just saw a circle with a bunch of other little circles in them. And so you'll notice that surrounding each of the axons is actually a sheath of connective tissue. You do not need to know these words, but that just describes the connective tissue that surrounds the different layers. And so the endo means inside. So that's the innermost connective tissue layer. And then notice how the axons are bundled into fascicles. So fascicles are just bundles of axons. And then surrounding the whole nerve, we have connective tissue layer. And then notice that there's blood vessels that actually supply nutrients to the nerves as well. Okay? And so this is why a nerve, like a muscle, like your biceps muscle, is actually not just tissue, but it is actually an organ. So each of your nerves is an organ. Okay. So this is kind of what it sometimes looks at. This is actually not using a light microscope. This is actually looking at a microscope with a higher resolution, which is called an electron microscope that takes kind of black and white pictures. And so this is a high resolution showing what a nerve looks like. Okay. So we can talk about what happens when nerve fibers become damaged. And so when we look at the CNS, in the CNS, we get very little, if any, nerve fiber regeneration. So none or little regeneration. And that is an area that has lots of research in it, because if you think about this, this would include the spinal cord injuries. Okay, so this includes spinal cord injuries. Okay, so when a nerve fiber gets severed due to an accident, for example, it could be the entire nerve, it could just be some of the nerve fibers, there is very little growing back. So there is actually inhibitory chemicals that actually go in and lay down scar tissue. And so like when they looked at my MRI of my neck, they noticed that scar tissue was starting to form in the spinal cord where I had the herniated disc, right? And so that suggests that once you get damage to the spinal cord, you cannot repair it, okay? So in the PNS, we have regeneration, but it is relatively slow. Oops, regeneration. So it can take several months to maybe even a year to regenerate. And it has to be that the fiber cannot be separated extensively. And so there has to be, the pieces of the fiber have to be close together. And the reason for this is that Schwann cells play an active role. Okay, and so in the promotion of regeneration. So remember that we do not have Schwann cells in the brain and the spinal cord. We have oligodendrocytes instead, and those oligodendrocytes inhibit regeneration. And so the question is maybe if we could get the oligodendrocytes to behave more like Schwann cells, maybe we could maybe that could allow for some regeneration in the brain and the spinal cord. So in your book, there are some diagrams of what this looks like. And so this is just showing one nerve fiber. So that is the axon. And you'll notice that here, the axons, oops, I think I went too far. There we go. So notice here, there has been damage to an axon. So notice that myelin is present in this particular area. And there needs to be, I think I heard this, I read, that was 3 centimeters. So it's got to be relatively close, right? So if you have separation of the nerve fiber, then there's a bigger space between the two ends, then it is much harder to regenerate. Okay. So the first thing is that you have a fragment of the axon, right? And then you have these macrophages that go in and actually clean up the injury. So they essentially eat the fragments of the axon. And then what the Schwann cells do is that they form a regeneration tube. So notice that the Schwann cells kind of reach out their cytoplasm and create a space for the axon to regenerate. And then you get these axon sprouts. And the axon sprouts start at the end that is closest to the cell body. And so they regenerate the same direction as an action potential travels. So you'll notice that the sprouts form, and this could take 3 months, right? And then eventually you get the regeneration of the entire myelin sheath. Okay? And so that could take 6 months or longer. So it's a relatively slow process. So say, for example, if you have cut your hand and there is nerve damage, perhaps they would be able to regenerate it. But in some instances, sometimes the cuts are so severe that they cannot regenerate themselves without surgical. So one way that they would do that in the past is that they would actually take a nerve from a different area and kind of stick it in the space and hope that that would actually, a piece of a nerve, that would actually help with the regeneration. But if you're taking a nerve from a different space, then you might get numbness in a different area of your hand, right? And so I'm going to show you just a short, quick video that talks about using cadaver nerves. So you can actually take nerves out of freshly dead people that have not been preserved, and then you can actually use those nerves to create a tube in which the regeneration can occur more quickly. So
and accidents all can cause devastating nerve injuries. Sometimes the body heals on its own.
Your peripheral nerves, so the ones in the arms and the face, have an inherent ability to regenerate, but only under ideal circumstances.
With support from the National Science Foundation, University of Florida biomedical engineer Christine Schmidt is working to restore nerve function when injuries are more complicated.
Took that muscle and rotated it, took it all the way back and fell off.
Surgeons can sometimes move a nerve from one part of a patient's body to another. Schmidt has developed a method that grafts cadaver tissue onto the damaged area to act as a scaffold for nerves to regrow themselves.
Basically what we're doing is removing all the cellular material that would cause rejection, but leave behind the native architectures. You're putting this graft into the site of injury. And now that graft is providing a scaffold for blood vessels to grow in, and then once you have that recellularization, your nerve fibers can then regrow, so then ultimately regain that muscle function.
Navy veteran Edward Bonfiglio, wounded in Afghanistan, faced the prospect of an amputation. A graft was a welcome option. The company Oxygen distributes the grafts, which were developed based on work done in Schmidt's lab.
And his family pressed the doctors to say, are there any alternatives? He was a young, healthy, vibrant guy. And they had a great surgeon at Walter Reed who was willing to work with them to find those options. This is some of the micronized nerve that you're working with.
Schmidt and her team are also looking at other approaches to directly stimulate nerve growth, using natural sugar molecules found in the body as building blocks, eliminating the need to transplant tissue.
So you don't have to actually take it from someone's body, you can grow it.
While the ultimate goal in nerve regeneration is reversing paralysis, Schmidt says intermediate successes, like improving lung or bladder function, can be invaluable to patients and their families.
So rather than saying we're going to try to tackle this humongously complex beast and try to get the patient to necessarily be exactly like they were before, why not provide some function that will have merit to this patient?
So after a serious injury, it's not just about getting your nerve back, it's growing it back. For Science Nation, I'm Miles O'Brien.
Okay, so sometimes, you might have an injury and it'll leave you permanently unable to move a muscle, or it might actually also, remember, it's sensory, so it could leave a particular part of your body numb, right? So the nerve, damage to the nervous system can cause numbness as well as paralysis. Okay, so with the guy, with the leg, there are some major big nerves that run down the leg, like the sciatic nerve. And so that he would need a big, one of those larger cadaver scaffolds in order to regenerate that, help to regenerate that particular nerve. Okay, so we talked about the cranial nerves in lab, and so I'm just going to briefly review them here for you. But remember that some cranial nerves are sensory only, some have sensory and motor, and some also are motor only. And then if you look at the table in your book, you'll notice that there is another category that I didn't mention in lab, but that we kind of looked at when we were looking at the pupil and dilation and constriction, and when we looked at accommodation, or the ability of the lens to change shape to focus light on the back of the eye, on the retina. And so this has to do with parasympathetic. And so we have some parasympathetic fibers in the cranial nerves. And so, for example, with the ocular motor, we'll talk about this. This also innervates the tear duct, the tear gland, and causes tears. And then when we look at the facial, this will also innervate some of the salivary glands that cause saliva. And so when we're talking about parasympathetic, we're talking about autonomic function. So it's innervation of the smooth muscle, the glands, and I think that's it for the cranial nerves. Okay, so for the lab practical, but also for the midterm, you do need to know the 12 pairs of cranial nerves, and that you also need to know their numbers, so their Roman numeral numbers. And so when we look at the olfactory nerves, I mentioned in lab that the olfactory nerves actually extend down into your nasal cavity. And these are specialized receptors called chemoreceptors that are able to bind odors. So the chemical binding is what causes the sodium ion channels to open and an action potential to be generated. And you'll notice that it then goes to the olfactory bulb. And so if you remember from 231, we did look at the skull, and that there is a part of the skull that has little holes in it that's called the cribriform plate, and that's where those neurons reside. Now, sometimes we smell chemicals, sharp chemicals like maybe ammonia or other chemicals that can actually damage our sense of smell. But these fibers are also capable of regeneration. So they are part of the peripheral nervous system, remember? So the olfactory nerves are part of the peripheral nervous system, so they can regenerate. And so sometimes it's really awful when you lose your sense of smell. So like I had a virus that caused my sense of smell to completely change. It was just so weird. Lavender did not smell like lavender, right? I did not smell like myself, right? My husband did not smell right. Nothing smelled right. And it took like a year before my smell came back to normal. And the doctor thinks it was just a virus that affected my olfactory nerves, okay? So that's the cranial number one. And remember that the olfactory bulb has a connection to the limbic system. And so sometimes smells can be perceived unconsciously and cause a reaction by the limbic system, an emotional response to that stimuli. Okay, so the next one is the optic nerve. So that would be Roman numeral number 2. And one of the interesting things about the optic nerve is that it crosses over, but not completely, at the optic chiasma. So if you had damage at the optic nerve, say, for example, right here. So if you had traumatic damage to that nerve, you would lose your vision in one eye only, right? And it would be complete. It would probably be a complete loss of vision in one eye. So like if your eyeball pops out and it damages the nerves, you could lose vision, right, from that. But if it's in the tract, which is in the nervous system, notice the way that the fibers cross over, but only some of them cross over. So the lateral, from the lateral peripheral vision, it crosses over. Oops, excuse me, not the lateral, the medial peripheral vision crosses over. The lateral stays to the same side of the brain. And so if you get a damage here, you're simply going to lose, you're going to lose vision in the medial, in the middle, so just part of your field of view. So determining how you see and what vision loss you can determine where the damage has been done.
Is that on just one eye or both?
That would be on both. So it's if it's after the chiasma, notice that there's fibers coming from this eye and from this eye. And so it would be partial loss of vision in both eyes. And then notice how then you have fibers that take it out to the visual cortex. And I mentioned before that you could get hit in the back of the head, right? Or even in the front of the head because your head can bounce. If you get damage to the back of your skull, then that could be due to loss of vision as well. Or that could cause loss of vision as well. So there's lots of different things that could cause one person to lose sight. And we'll talk more about the eye when we get after the midterm and we talk about special senses. Okay. So those were actually both sensory only. So then the next one is the ocular motor. And so here you can see that the ocular motor is innervating what we call the extrinsic muscles of the eye. So what an extrinsic muscle means is it's outside. Okay, so this is versus intrinsic. So this is actually the movement of the eye. And that would be obviously a motor function of that process. But if we look at the ocular motor, it also does the intrinsic. So this would be parasympathetic. So this causes pupil constriction. Oops, I'm running out of room. Pupil constriction. And it also changes the shape of the lens. So it's motor, but it has a parasympathetic function. So the iris and the ciliary body are smooth muscles rather than skeletal muscle. Okay. This one would be motor. So the trochlear also innervates an extrinsic muscle. but it is a different muscle, and it actually has to do with the way that this muscle attaches to the eye. It actually has a little trochlea, which is kind of like a little, what do I want to say, if you're creating a, not a lever, but if you're looping something up and over, you're creating, what is that called? Mechanically, you should know.
Yeah, mechanical advantage.
Yeah, but you're a pulley. Yes, sorry.
Oh.
So trochlea is a pulley system. And so notice how that muscle, I kind of wrote over it, but notice how that muscle has a little pulley. It's a pulley involved in that. So that the actual tendon extends through this pulley system, and it would pull on the eye and cause it to elevate, right? And actually move medially as well. Okay. So the trigeminal muscle is the largest cranial nerve. So you'll notice here that it also has a ganglia associated with it. And so what would be inside that ganglia? They're not myelinated axons, that would be the cell bodies, right? So the trigeminal nerve, right, has a ganglion associated with it, okay? So those would be important for sensory neurons and also for the parasympathetic division, which has ganglia. And so when we look at the divisions, we have the ophthalmic. So this means eye, right? So this is sensory. So it would cause you to blink, right? If you're exposed, if something touches your eye, you blink, or your eyelashes, right? But it also has an autonomic nervous system function. And so it innervates the lacrimal gland. And so it is involved in tear production. So this is the nerve that causes you to tear up. And it could be just due to irritation of the eye. We also have a maxillary division. So maxillary division. The maxillary means it is the upper jaw. And so notice how this one actually would innervate kind of the cheek, but it would also innervate the teeth. So this is sensory. So if you have a toothache, a really bad toothache, then this is the nerve that is going to be sending pain impulses into the central nervous system. And then for the facial, we also have, so this is sensory only. We also have the mandibular division. So that's why it's called trigeminal. Tri means three, right? So 3 branches of the trigeminal nerve. And so this has sensory. So this would be, for example, the lower teeth. And so when they go in and they give you that shot, which is the worst thing ever when you're at the dentist, right? They have this huge needles and they're giving you the shot to cause it to become numb. This is what the nerve that they're trying to prevent action potentials from being generated on. So you notice that you stop losing sensation, maybe even in your tongue, right? When they do your lower jaw, like you have a cavity to fill, and then you lose sensation in your chin, you can't feel anything, right? And your face might droop a little bit. In the tongue, there's also, this is motor. So this would actually be the tongue muscles that kind of allow it to move, to speak and to move. Let me get my notes here. Facial, oh, sorry, trigeminal. Okay, so we'll just put to the tongue. So there's some motor neurons to the tongue and to the jaw. Okay, so that's the largest cranial nerve. Okay, so the next one goes back to the eye. So this is called abducens, and abducens is primarily motor. And so it, again, is just innervating those eye muscles, those extrinsic eye muscles that allow the eye to move. Okay, so this one's the facial nerve. And so the facial nerve also has branches. I'm not going to make you learn the 5 different branches of the facial nerve, but this includes sensory, and it also includes parasympathetic fibers. So it has sensory, and PS fibers. And this is because notice what it innervates. If you look underneath the jaw, you have the submandibular salivary gland and you have the sublingual salivary gland. So these are submandibular and sublingual salivary glands. There's another salivary gland, which is the parotid, which is innervated by a different cranial nerve. So this also innervates the skeletal muscles of the face. So it also has a muscle function. And so there is something that sometimes happens to people where they might go to sleep and they'll wake up and one side of their face is all droopy. And so that particular illness is what is referred to as Bell's palsy. Has anybody ever known anybody with Bell's palsy? Okay. And so it's very, very disturbing because you think you've had a stroke, right? Because your face is drooping. But in the case of this particular thing, it is generally inflammation of the nerve, and it seems to be associated with viral infections, specifically a type of herpes viral infection. And so it simply is not due to a stroke, right? So we'll put not stroke. So that would be the central nervous system. But it is due to inflammation around the facial nerve. Sometimes, because they're unable to close their eyes or to feel pain in their cornea, then sometimes during this period of time where their face is paralyzed, sometimes they'll damage the cornea, so they'll lose partial vision in that. So one of the really interesting things about this particular one is it tends to be reversible. So all on its own, people tend to just over time, gradually over time, develop the ability to smile, for example, and the ability to sense their face and to move their facial muscles. However, there are people that you might see that might just have, like, when they smile, like one side of their mouth will droop. And so sometimes it can remain minor for long periods of time, for a lifetime, right? So some people have the effects that last, but generally not as bad as when it first started.
Can physical therapy help that? No. You can't really like retrain the nerves to kind of.
Well, it's due to pressure on that nerve, so action potentials are not being sent. So I don't think that they do
I guess
physical therapy for it, but I'm not sure about that. I'm not sure about that.
Maybe because if it's inflammation, trying to,
Yeah. I'm not sure if they do physical therapy for Bell's palsy, but you could look that up really easy and see. Okay, so the next one is the vestibular cochlear nerve. And this is a really interesting one because it connects to the inner ear. And it is also mostly sensory. So there's different parts of the inner ear. The cochlea hears sounds. right? So that's where we, those action potentials that come from the cochlea are going to go to the auditory cortex so that we can understand what somebody is saying. Okay? But the vestibule is all about balance. Right? So if somebody has damage to the vestibular cochlear nerve, they might have the inability to hear, but they might also feel really dizzy, right? So they have no orientation between like what is up and what is down, orientation to gravity. And if it's damaged, then sometimes they'll feel like they're spinning. So this can feel like vertigo. And so that can be a really bad sensation. I guess that's like a really bad symptom to have is if you're constantly dizzy, if you can imagine like constantly feeling like you're spinning, then you can't stand that forever. And so a lot of people will just kill themselves because it is so bad, right? So that all has to do with these semicircular canals.
They're starting to put tubes in people's ears that'll control that because I actually got really sick with that one time. I was on medication for like a year because you just feel like your head's constantly like this and you can't, not like crazy thoughts, but you can't control the speed at which your brain is processing that kind of information. So when someone's talking to you, it's just like, it sounds like they're on like,
so you had problems with this nerve in particular?
Well, they told me that they thought it was just an equilibrium problem, and then they put me on that medication and they're like, well, unless it gets worse, don't come back for a year. I came back for a year and it was just inflammation of the ear, like a different type of ear infection, I guess.
Oh, interesting.
And they thought that if the medication wasn't going to work, they were going to put tubes in my ear instead of having equilibrium to where your body was almost confused as to where now you don't have that nerve anymore.
Right.
You just have a tube in there. But
right.
It kind of fixed itself and
oh, thank goodness.
Hasn't been an issue. But yeah, I mean, you feel like you're walking around like this with your head tilted or your head's back like this and you're trying to walk and you can't see. It's not very fun.
Yeah.
That was just minor. I can't imagine people that live with it for years.
Right. Yeah, so that's obviously an extremely important cranial nerve. And then we have the big nerve that we're going to talk about. This is cranial nerve number 10, and this is the vagus. And it is a vagabond, which is kind of, I guess, the way to remember that. So it travels. It is the only cranial nerve to travel down through the neck and into the body. And so you'll notice that it not only goes to the neck and to the voice box, so hoarseness can sometimes be due to damage to the vagus, but it goes to your heart and your lungs and your digestive organs. And so it has a big parasympathetic function. So it allows motor, right? So it might cause your heart rate to decrease, actually, and your breathing rate to decrease, but it actually causes the stomach to increase the release of gastric juice and to increase like a churning. So the smooth muscle of your stomach would churn in response to being stimulated by the vagus nerve. The other interesting thing about the vagus nerve is that it's also sensory, but it has the sensory, it can be visceral. So when you have pain, say for example, in the stomach or in your liver, that sensory travels via the vagus nerve back up to the brain where it can be interpreted. So visceral just means body organs. So we have two more. This is the spinal. And your book notes that sometimes people think that this cranial nerve should actually not be included as a cranial nerve, but it should actually be a spinal nerve because it originates in the cervical region. But it travels back up to the brain. So into the cranium before exiting. So it has, oops. Oh, I don't know how that, okay, before exiting. Okay. So if you touch your shoulder, that would be, the sensation would be traveling via the spinal nerve. If you move, like if you elevate and shrug your shoulders, you're moving the trapezius muscle. If you're taking your chin to your chest, you're moving the sternocleidomastoid muscle. And so both of those would be motor. So it has both sensory and motor. So these are the two muscles, the trapezius muscle, and then this big strap-like muscle in the front of your neck. When it contracts, you go like that, and that is also innervated by the spinal nerve. Okay. And then we have the hypoglossal. I think I skipped over the glossopharyngeal. Oops, sorry. So glossopharyngeal, I don't have an image of it, but glosso means what? What?
I said shiny.
No. What does glosso mean?
Big?
Tongue. Glosso means tongue. And so we also have the glossopharyngeal, but we also have the hypoglossal. So glossal means tongue region. And the hypoglossal is interesting because this is the one that is important in chewing, swallowing, and speech. So if you're a speech pathologist and people have lost the ability, then you can go to physical therapy and you can learn to use those muscles to make sounds, right? To make certain sounds. And it's kind of interesting because obviously in different languages, some languages omit a sound. And so people never learn how to say that sound. And so they have to learn another language, oftentimes you have to retrain the muscles of the tongue so that they can make a particular sound that is particularly important in that type of language. Okay, so those were the cranial nerves. So now we're moving on to the spinal nerves. And how many are there? How many spinal nerves are there? There's 12 cranial nerves. I already mentioned how many spinal nerves, but there are 31 pairs. So there's actually 8 cervical instead of 7 cervical. You learned that there were 7 cervical vertebrae, but there's a spinal nerve that comes out the top, and that is considered the first. So there's actually 8 cervical vertebrae rather than 7. So remember that one way to learn that is it's like breakfast, lunch, and dinner. So it's like 8, 12 is the thoracic, and then 5 is the lumbar. So there's 5 lumbar vertebrae, 12 thoracic, 8 nerves that come off the cervical region.
And then there's 5 sacral.
Sacral, yes. So 5 sacral. And then there's, how many coccygeal? 1? Yeah, 1. So that's, coccyx is the tailbone. Okay. So these are all mixed. And instead of coming off the brain, the middle of the brain, or the medulla oblongata, for example, like a lot of those spinal nerves do, these come off of the spinal cord. So when we look at these spinal nerves, we're going to go back to that image that I gave you right here. And I don't have any extra copies of this. Did everybody get a copy? So this had the receptors on the front. Okay. So remember that this is dorsal or anterior, posterior. So that's to the back. And this is ventral or anterior, which means to the front. So we can talk about the spinal cord, and the ventral horn is the gray matter. So this is my ventral horn. And sensory information travels via the ventral horn. And so we call the ventral horn. So we call this the ventral root. And I'm going to put sensory. So all sensory information comes in. Why am I saying ventral? Sorry. Sorry. Dorsal. Glad I caught that. Dorsal. Okay. So all sensory information comes in via the dorsal root. Okay. Now, we have this little enlargement here, and this is what is called the dorsal root ganglion. So it contains cell bodies, because all ganglia, which are in the peripheral nervous system, contain cell bodies. So those would be the cell bodies of the sensory neurons. So if we look at the other side, right here, this top little structure, notice that the cell bodies are in there. This is the sensory neuron. Okay, so this would be the ventral horn. This is the ventral root. Notice that there is no enlargement. There is no ganglion. And the reason why is that all of the motor neurons have their cell body in the spinal cord. So their cell bodies do not exist outside of the spinal cord. And so this would be the motor neurons. Right, they're coming out. So the crazy thing is that all of the nerves that go out to your skeletal muscle are that long. They start, the cell body is in your spinal cord, and then the axons extend all the way out. And so this is the longest, right, cell in the body. This is a cytoplasmic extension that extends out to all of your skeletal muscles, right, and can cause contraction of the skeletal muscles. So this is actually why, if you look at it, the dorsal horn is smaller than the ventral horn, because the dorsal horn has its cell bodies here. The ventral horn has all of its cell bodies here. So that's why the ventral horn is bigger. So I'll put ventral horn larger than dorsal horn. Okay. So where those roots come together, right here, where they come together, this is the spinal nerve. So this is why all spinal nerves are mixed. They have a sensory and a motor function. So if we look down at kind of a side view of the spinal cord, notice that we have, in any given area, we have these branches, and these are still the branches. These are still the dorsal and the ventral, but these branches are called rootlets. So this would be the dorsal rootlet. Right? So they're small branches, and these would be my ventral rootlets. Oops, how do you spell rootlet? Rootlet. Okay, so those are just the tiny little branches. So notice how they actually all come together, and then they come together and form the spinal nerve. So this would be still the ganglion. So there's my dorsal root ganglion. Right? But notice that the spinal nerve is super short. So this is like my spinal nerve. So they are like 2 to 3 centimeters in length, which is super short. So that is just where the dorsal rootlets come into the dorsal root, and then they combine with the ventral root, and then they form this tiny little short, right, spinal nerve. The reason why it's short is that it immediately branches. So its branching are called rami. So this is what is called the dorsal rami or dorsal ramus. So see that branching? That is going to go to your back body. So that is those branches are going to serve your large back muscles and also like the skin. So like if you're touching the back body, the sensation is going to come through the dorsal ramus to the spinal nerve and then into the spinal cord. Okay. This is what is called the ventral ramus. So plural of this are the rami. Right? So if you have multiple ramuses, you don't call them ramuses, you call them rami, right? So this is, notice that is much larger. So the ventral ramus is going to go to all the muscles on the front side and actually the side of your body. So it's going to have the muscles, but it is actually then going to go to all of your organs. So the ventral ramus is the front side body and organs. The dorsal ramus is just the back of the body. Now, coming down along the spinal cord, you'll notice that there are these ganglia. So this is what is called a sympathetic ganglia. So this is a part of the autonomic nervous system. And this is going to be where the signals that cause fight or flight are going to originate from. So when we talk about parasympathetic in the cranial, the sympathetic division of the autonomic nervous system actually comes off the spinal cord, not the brain. So it doesn't come off the brain. So that's why I didn't talk about sympathetic when we were talking about cranial nerves. And notice how this kind of runs really close to the spinal cord, kind of up and down, and then it communicates with the ventral rami, right? So I'll put, we have rami communicants, there's a cants. Oh, I can't remember. It's either C-A-N-T-S or C-A-T-S. Okay, so I think it might be A-N-T-S, I'm not sure. So the rami, actually, you know what? This is the amazing thing about Google is all I have to do is type in rami, and it tells me it's not spelled like that. It's C-O-M-M-U-N-I. There we go. So the rami communicants is where the sympathetic nervous system comes out, and it is going to then signal from the ventral. It's going to go to your heart, to your digestive system, to your blood vessels, to all your lungs, for example. And so these communicate with viscera. So viscera means organs. Okay. So this is a diagram in your book that just shows a different view of it. So notice that here, this is the dorsal rami, and it's innervating your back muscles. This is the ventral rami, and it's coming all the way around, and it's innervating your front and side muscles. So if I'm going to contract my trunk like this, right, it would come from signals that are going out the ventral rami of the spinal cord. Okay. Now, an interesting thing about our spinal cord is that you can map where the sensory information is coming from and where it goes into the spinal cord. And so these are areas of the body with sensory stimuli entering different parts of the spinal cord. I just want to put an H on cord, spinal cord. Okay, so this can be very useful to doctors. So if you have damage or if you have a pinched spinal nerve, say in the neck region, so let's say that I am feeling pain and maybe numbness right here on this outside, my thumb side of my arm, right? So you go to the doctor and you're like, I have a lot of pain down the side of my arm and into my thumb. And the doctor will go, oh, that's really interesting because that corresponds to, was it C5? Is that right? Oh, let me see if C6. Okay. So they're like, oh, well, maybe you have a pinched nerve in C6. So remember that when you get a herniated disc, sometimes it doesn't press on the spinal cord, it presses on the nerves. Because the nerves are really close to the spinal cord, so that herniated disc can actually press on the nerve. And so generally, if it is on just one side, then that means it's pressing on the nerve. If it's like, if you're feeling pain down both arms, then that could be the spinal cord. So let's look at sciatic pain. So if we look at the back of the body, right? And let's say you have pain right down the back of your leg and towards your foot. This is S1. Okay, so that means that's the first sacral vertebrae. So the most common herniation that people have is called the L5-S1 herniation. So this is associated with sciatica. Sciatica is the major nerve that goes down the leg and it exits from this part of the spinal cord. So this can be excruciating, let me tell you. So I've had it a couple of times and I have ended up, like, it takes me to the floor. I'm in so much pain. So it's like, for sciatica, sometimes it can be like, it's kind of like a calf cramp, but it's in your butt. And so it's like, if you can imagine, you know what calf cramps are like, where you're just screaming, right? It's in your butt, and so you lay on the ground screaming, right? And so you can massage it. The thing about this is that it innervates some muscles that can also cramp up. And so not all sciatica is due to a herniation. However, there's another tightness in a particular muscle, which we'll learn about, called the piriformis, can also cause sciatica. But sciatica can be caused by this herniation. So these dermatomes are just really, it's a helpful map so that they can determine where that damage to the spinal cord or pinched spinal nerves could be coming from. So it's kind of a cool map to look at. Okay, so we're going to start today on the reflexes, and I want to ask you if you could, I think it's going to be nice on Friday. So if you could wear some pants or shorts or a skirt that you could roll your leg up. So we need access to your thigh about 7 inches from the knee, right? So if everybody wears tight pants, we can't do it without taking our pants off, right? So you don't want to wear tight, you know, those pants that are just like you can't even get over your calf. Skinny, no skinny jeans on Friday, okay? So if you could wear something so that we could have access to your thigh muscle. Okay, so when we talk about a reflex arc, first we need to talk about the reflex part. So the reflex is a fast, automatic response to a stimulus. And when we talk about spinal reflexes, we say that the integration of the sensory information into a response, or the integration of sensory information into a response occurs in the spinal cord only. Okay, so what that means is it doesn't involve the brain. So spinal reflexes do not involve the brain at all. And they're actually really important for just kind of allowing us to stay upright, right? The spinal reflexes keep, when I'm walking, right, they will contract the right way and relax the right way to keep me from falling over. So spinal reflexes are very, very useful, right? So when we look at the spinal reflex, this is a diagram from your book. You'll notice that sensory information comes in versus the dorsal root. And then we have an interneuron. So this interneuron is a neuron that connects then to a motor neuron. So the interneurons determine whether or not the reflex is polysynaptic or monosynaptic. That's what I want to say. So when we look at the classification of reflexes, so these are the terms that you would kind of hear when we talk about spinal reflexes. Okay, so monosynaptic. So mono means one. So that would mean that there is no interneuron. I should say neuron. Okay. Versus polysynaptic, which means that interneuron is present. So some reflexes are monosynaptic and some reflexes are polysynaptic. This one shown would be polysynaptic because we have a synapse here and we have a synapse here. So remember, the synapse is just the space between the neurons. So I have two synapses in this particular reflex. Okay. We can also talk about reflexes that are ipsilateral. And this means that the stimuli and the response occur on the same side of the body. So the stimulus and response occur on the same side of the body. And this is different from contralateral. Kind of running out of room here. The contralateral means that the stimulus is on one side and the response is on the other. So the stimulus is on the opposite side of the response. So contra means other side. Okay. And then there's one more, and that would be consensual. So consensual means that the stimulus is on one side, but it causes a response on both sides. So consensual would be like if I maybe my salivary reflex. If, that's not really a good one. It's not a spinal reflex. People, that's not, we'll talk about consensual. I think I have some examples of it. So you stimulate one side of the body and both sides respond. So that's consensual. So which is the one in the drawing? Is it ipsilateral, contralateral, or consensual? Anybody want to take a guess? Ipsilateral, right? Because this didn't cross over. If this crossed over, so if the stimulus was on one side and it crossed over and innervated a muscle on the other side, then it would be contralateral, right? If it did both sides, like if it had both connections, then it would be consensual. Okay, so the first type of spinal reflex that we're going to talk about are stretch reflexes. And these are the ones that we're going to look at in lab. And this is an interesting one because in response to being stretched, the muscle actually contracts. So in response to stretching, the muscle contracts. And you might have experienced this. I experience this all the time when I exercise. Like I stretch out and I'm exercising and then I stop exercising and I go sit on the couch, right? And then I get up and I'm like, oh, I'm so stiff, right? How did that happen? I had just been stretched out. And the thing is that when you stretch your muscles will respond by contracting to maintain the proper length. So muscles contract to retain the proper length. So these stretch reflexes actually have a type of mechanoreceptor called a muscle spindle. So this is the receptor. And this has specialized muscle fibers. Connected to sensory neurons. So the muscle spindle is a simple, it's encapsulated because it is in a connective tissue sheath, but all of your muscles have muscle spindle fibers in them to tell their relative length. So if they're stretched, if they're contracted, or if they're like relaxed but ready to do work. Okay, so in your book, they have a picture of this. And so this just shows a muscle, and this would be my muscle spindle right here. And so notice that it is spindle shaped. So it kind of looks like this, right? A spindle shape kind of looks like this. Oh, that doesn't look right. Like this, right? That's a spindle shape, okay? And notice that there are sensory endings that wrap around these specialized muscle cells. And when those muscle cells stretch, they send action potentials into the spinal cord. So it's not really into the brain, right? But into, in this case, the spinal cord. And so if we look at how this works, so kind of ignore this for right now. We probably won't get into that much detail. But notice that there's action potentials kind of being sent into the spinal cord even when the muscle is unstretched, right? So there's a certain frequency of muscle or action potentials being sent to the spinal cord. And then all of a sudden the muscle stretches and the brain or the spinal cord is like, whoa, because notice that the frequency of action potentials change. And the spinal cord can sense this and cause a response. An involuntary response to the stimulus of being stretched. And so a good example of this is what is called the knee jerk reflex. Okay. So let me show you the picture of this. Okay, so this is the patellar reflex. And you probably have had this done to you at the doctor's office. So the stretch receptors are in both the quadriceps and the hamstring, so on top of the thigh and on the bottom. But when you hit the patellar tendon, what is going to happen is it's going to cause your quadricep to stretch. So if I hit this tendon, it causes stretching in my quadricep, and what is going to be the response? My knee is going to kick, and the quadricep muscle actually contracts, right? So we have the stretching. This one contracts, and it causes the leg to move. But we also have to make sure that the hamstring is not contracted. So that's why, like, if you're standing, the knee-jerk reflex wouldn't work. But also, like, if you're just contracting your muscles in your legs and your thigh, both sides, it's not going to work. So they say relax the leg, right? So the hamstrings actually have to be relaxed. And so there is a motor neuron going to them that is causing that muscle to relax while the quadricep contracts and causes the movement. And so you'll notice that this is ipsilateral. You'll also notice that it is a polysynaptic. So there's interneurons in the synapse. And then you can also see the route by which the sensory information goes into the spinal cord and the motor information comes out of the spinal cord. So why do you think doctors do this?
Test your reflexes. Make sure that.
So to test your spinal cord, the health of your spinal cord, because if you have spinal cord damage, your reflexes are either going to be low, like you're not going to have reflexes, or actually what I discovered when I went to the doctor, I was hyper-reflexive. So because I had a pinched spinal cord, when they did that, my leg just like, whoa, and my arms would just go like, whoa. And so I was actually hyper-reflexive, and that's a sign of something wrong too. So not having reflexes, but being hyper-reflexive tells the doctor something about the health of the nervous system. And if there's pinched nerves, there's something neurologically wrong, right? And oftentimes what happens when you get a pinched nerve, so like if I pinch a nerve here, right, the action potentials stop being sent to the muscle, and so it actually causes the muscle to become weak. And so when you have a pinched nerve, a spinal nerve, or damage to your spinal cord, you'll start to notice that you'll get weakness. You might not necessarily lose total function, but you'll get weakness in the muscles because the muscles are not receiving the proper action potential to keep them ready for contraction. So those muscles will start to get smaller because they're not being used as much. Okay, so on Wednesday, we'll talk a little bit about the spinal nerves, but we're going to talk about spinal nerves in lab too. But remember that we have one more quiz before the midterm exam. So that quiz will be on Wednesday. And everybody got the review sheet, right?
Wait, Monday or what?
Or Monday,
Okay.
sorry. The
The
quiz will be on Monday, yes. Okay.
I need one, I'll come up there though.
I'll answer you. It will automatically count it.
Oh, okay, okay, not a problem, just wanted to check.